This is presentation number 15 in the GIT series. We'll deal with the liver solid focal lesions prepared by Prof. Sharaf and revised by Prof. Hani Sami. Let us take this first slide. Now here in this image you hardly see this lesion, but once you start to inject, so we can say that it's appearing hypodense. When we start to inject, we have the nodular outline which is increasing with time, and in delayed images it is almost trying to fill the whole space, and this is called the closing iris sign, and this appearance is characteristic for hemangioma. But let us say this area appears a little bit abnormal density, and in early arterial it starts to show here, but in this one it rapidly washes in delayed scans. So it is a lesion with abnormal density which rapidly enhance and rapidly wash out, and this is an example for carcinoma. This is an angiographic appearance of hemangioma, where we have the nodular capillary and blood pools delineating the lesion, and looks like a nodular margin. In hyalinized hemangioma, we have the T2 image seen as a little bit hyper-intense, while in T1 it is definitely hypo-intense, and this is called hyaline degeneration of hemangioma. Here we have the MRI in T2 weighted images seen as a hyper-intense lesion, and in ultrasound seen as hyperechoic, while after contrast it presented the same nodular marginal enhancement. In this one we have a giant one, which again appear as abnormal low density of the liver, of rather well defined and well demarcated, and after contrast we have the nodular marginal enhancement, which reflects the blood pools at the margins and the capillary bed surrounding the compressed capillary bed surrounding the lesion, and it starts to fill. Again, this is a giant one with different appearance. It's not homogeneous. It can present necrotic center because of the large size, but still we have the nodular margins starting to appear from the margin creeping inward, and in delayed we have larger patches of contrast enhancement along the margin with relatively trial to fill this big mass with contrast. Another hepatic hemangioma with the nodular marginal capillary blood pools. This is the mass, this is the nodules start to appear, and this is how closing iris sign succeeded in producing a rather homogeneously enhancing tumor, hemangioma. Giant one with nodular enhancement starting to fill from the periphery, but it failed to fill completely, and thus another suggestion that it could be a hepatocellular carcinoma is breaking down. Here we have a very large mass lesion seen as hypointensity in the MRI in T1 weighted images, focal hyperplasia with dense scar inside. Hypodensity in CT, homogeneous enhancement in arterial, and enhancement similar to the liver, reaching that of the liver, with central scar. So the key point here is the presence of a central scar. In adenoma, where we have such an appearance in T2, minimal hyperintensity, hypointensity in T1, and irregular contrast enhancement in T1 with contrast. So the key point is the heterogeneous enhancement in T1 weighted images. Now in this one we have a hypointense area which starts to be enhancing in early arterial and in arterial phase, while it becomes starts to fade at the margins in the portal phase or venous phase, and in delayed we regain its hypointensity compared to the liver. So there is definite washout. So early enhancement with starting washout in the portal or delayed phase, which is completed in the delayed one. This was a carcinoma. These are the characters of carcinoma. Multifocal lesions of the liver, query deposits, query multifocal hepatic carcinoma, area of enhancement, abnormal enhancement on CT in a fatty liver. This fatty liver with an area of abnormal enhancement in the arterial phase, which should be considered the malignant till otherwise proved. The margins are ill-defined. In ultrasound with contrast, this again shows early enhancement with contrast. This plastic nodule with central T1 10 seconds after contrast here shows the hypertense center, in a less intense dysplastic nodule, while in the proton density and T2 weighted images it is rather appearing here as in T2 weighted images appearing iso or intermediate intensity, while here it is it's mildly hyper intense in proton, and in the T1 weighted images it becomes more hyper intense malignant nodule within the dysplastic nodule. So hepatocellular carcinoma usually presents contrast enhancement similar in pattern to that occurring in CT, especially in arterial phase, early figure. This is hepatocellular carcinoma in cirrhotic liver. This is a T2 weighted image with super paramagnetic iron oxide contrast. It's only appearing in this one with contrast. T1 weighted images. The tumor was identified only in that paramagnetic contrast agent, while in T1 weighted images it's not seen. This is 10 seconds and this is 40 seconds. It fails to show except hardly, while in T2 it is again difficult to be seen, while this one with contrast is apparent. So sometimes you need to give special type of contrast. Hepatocellular carcinoma, CT shows the inferior vena cava thrombus. More caudally the tumor and right portal vein thrombus. And the tumor is there. This is hepatocellular carcinoma with inferior vena cava and portal vein thrombus. Inferior vena cava and portal vein, right branch, thrombosis with the tumor mass here, and the tumor is showing heterogeneous enhancement. Minimal ascites is seen. A residual ethidol retained in multifocal hepatocellular carcinoma oil. Radiofrequency ablation of hepatocellular carcinoma. Pre-therapy. This is the lesion. Early contrast enhancement. High dense lesion containing a hyperdense center. Here. Intermediate post-therapy. Residual changes 2 months later, but no enhancement. Still there is enhancement, but here there is no enhancement. 2 months later and immediate after therapy and early pre-therapy. So pre-therapy, immediate after therapy, and 2 months later shows that there is definite regression. Remember that there is cirrhotic nodules causing wavy outline of the surface of the liver with associated ascites there. Fibrolamellar carcinoma appearing as slightly hyperintense in the right lobe, almost iso-intense in T1 weighted images, but here it appears as slightly hyperintense in T2. So remember that malignant lesions could appear as mild hyperintense and not only intermediate intensity, but definitely it's of maybe iso or hypo in T1 weighted images. Liver hemangioendotheliosis in 1-year-old girl. This is the first slide showing malignant liver in infancy, 1-year-old girl, and this diffuse involvement is caused liver hemangioendotheliosis. Hemangioendotheliosis has a peculiar picture of multiple lesions showing irregular necrosis at the center. Hemangioendotheliosis is the first possibility in liver neoplasms of infancy and childhood period. This is the second one, is hepatoblastoma. This is a 2-year-old baby with very large mass containing central necrosis and calcification, and the lesion is slightly enhanced compared to the liver. We can consider it minimally enhanced, but this is our calcification and this is necrosis. So large masses with necrosis and calcification in infancy and childhood period is hepatoblastoma. So we have here the hemangioendothelioma and endotheliosis, which is a diffuse process, and here we have the hepatoblastoma, which is a very large solid tumor. The third one is the undifferentiated embryonal carcinoma, which appear as a cyst with fluid level, and almost this contains water density. This occurs also in infancy and childhood period, and this is the third differential for liver masses in the young age. Undifferentiated embryonal carcinoma. Undifferentiated embryonal carcinoma is a cyst-like tumor with blood precipitated fluid level due to their high water content. Often they show to be almost water density. The last differential is epithelioid hemangioendothelioma, which occur here in older age. A little bit older age, epithelioid hemangioendothelioma. So we have now hemangioendothelioma, epithelioid type. We have undifferentiated embryonal sarcoma. We have hepatoblastoma. We have hemangioendotheliosis in infancy. But still, hepatocellular carcinoma can occur in the young. Hepatoblastoma was in the differential diagnosis, but still the word hepatocellular carcinoma can be used, but this is a pathological diagnosis. Metastatic leiomyosarcoma. This is one of the secondary tumors occurring in baby. Metastatic leiomyosarcoma. We have a lot of metastases here. One of them is very big. All are showing as T1 hyperintense and T2 markedly hyperintense tumor, and the patient had a primary sarcoma resected 10 years ago. This is metastatic leiomyosarcoma. So we have hemangioendothelioma, hemangioendotheliosis, hepatoblastoma, undifferentiated embryonal carcinoma, and metastatic leiomyosarcoma. Metastatic meningeal hemangiopericytoma is another secondary meningeal hemangiopericytoma, and it is sharing the same picture of large mass involving the liver with breaking down central part, and this is called metastatic with known meningeal tumor, metastatic meningeal hemangiopericytoma. Multiple cystic metastasis, and here the lesion is pancreatic acinar carcinoma. This is not related to leuemia, this is general. Multiple cystic liver metastasis can appear as hypointense large masses from cystic pancreatic acinar tumors, malignant tumors. Another case of pancreatic deposits from all. Maybe we have now an idea that the intensity of such pancreatic, the density of such pancreatic tumors are usually hypodense in character. Here again, those hypodense from acinar carcinoma. Here again, hypodense, and usually pancreatic malignancy are of acinar origin, and that's why we produce the hypodense metastasis. Metastatic breast carcinoma in fatty liver can appear as nodules throughout a heterogeneous, poorly enhancing liver, but low density nodules. Hypovascular colorectal metastasis, similar to that of pancreatic carcinoma. Same changes here and there, here and there. Multiple hypovascular colorectal metastases. Here we have non-Hodgkin lymphoma, and here lymphoma is manifested by the attenuated, thin, elongated biliary radicals due to multiple infiltrations around in the liver, like this one, like that one, like this one. Infiltrations cause attenuation and thinning of the biliary radicals. There is a tube drainage, biliary drainage castle in place, and numerous narrowed biliary radicals are seen. Contrast enhanced CT scan shows multiple focal hypodense tumors. Appearance of non-Hodgkin lymphoma. No, don't forget that the spleen is mildly enlarged. Thank you.